I have with me today Dr. Mukesh Hariawala, who's a renowned, internationally renowned cardiac surgeon from Boston and has recently been conferred in the India's Most Admired Surgeon 2012 award in Bombay. Dr. Hariawala comes to India with a vision which he will explain to you he has of revolutionizing healthcare in this country through his groundbreaking new therapies. We welcome you, Dr. Hariawala, and it's great to have you here back in India.
Thank you very much, Sanjay. It's an honor to be invited by ANI, and I look forward to our conversation.
Sure. Just going back, Dr. Hariawala, you are basically a small town Indian at heart. You, based on what we've been talking about, your grassroots education and everything took place in India. After that, you went from strength to strength. You did your specializations abroad, and today you are on a situation where you have devised your own groundbreaking therapies which can address actually a lot of problems in the developing world. Could you just take us back on your journey, how you started and how you reached where you are today?
Well, Sanjay, I'll have to go back 52 years
You
in
don't
my
look
life.
52.
Thank you, thank you. That's very kind of you. And I'll have to go back 52 years. Is that my birth is in a very small town in Gujarat called Valsad, and I immigrated to Mumbai, big town, financial capital of India. At a very early stage, did my schooling over there, medical education, early surgical training over there. I got an opportunity to work with top Indian surgeons, Dr. Neetu Mandke and Dr. Bhattacharya. After finishing that training, I once again got an opportunity to, with the help of my Indian surgeons, to go to London, England, where I did subsequent additional training and including training in transplantation. In 1995, I reached a stage in my career that I could have come back to India, or I could go to the United States if I chose to, since I had several invitations. I chose Boston as it is the hub or the mecca of medicine in the world, and so I moved on over there, but things have worked out for me very well academically and even otherwise, and we have settled as a family in Boston.
Where did your interest in medicine come as a school kid? Did it come right from the beginning? Was your family part of the medical profession?
Well, in my days, which is in 1977, there were predominantly 2 or 3 professional career pathways that one could go
I
through.
remember those days.
Yes, absolutely. We are in the same age group, and you could either become an engineer or go to IIT or go to UDCT for chemical engineering, and the third pathway was medicine. I at that time never thought that I should become a doctor or a heart surgeon or things like that, but I chose medicine because I thought it was the easiest, rather than trying to be an engineer with a lot of mathematical calculation and a lot of brain involvement. I wanted to go in a path where there was less brain involvement and where I could do more things with my hands. So I just went for medicine.
So where did you do your medicine from?
I went to TN Medical College in Mumbai, which is affiliated with Nair Hospital, one of the finest institutions in the city and probably even in the country. It has produced several stalwarts in the world of medicine. So I am glad to be an alumni of an institution.
And how did your interest veer to surgery? I mean, there's so many branches of medicine.
Yes.
So
I took interest in surgery because I used to watch surgery, I used to watch great surgeons perform. I also got my best opportunities in surgery to participate in surgery with very good surgeons like I mentioned, and they kind of became my role models at a subconscious level. So all I desired that time is, can I be like them? I started idealizing them. It just happens to be that fortunately I have progressed and done well, but that does not mean I have started discounting idealizing them. They still continue to be my idols, because although I have worked across 3 continents, my idols are still the Indian surgeons as opposed to other famous surgeons that I worked in England and in America.
Okay, before I come to your vision, I'd love to know something about your research. Now, based on what you've told me, you have devised this groundbreaking new therapy, okay, for people with, let's say, end of the line heart problems or people who cannot afford transplants. Of course, we'll discuss the implications, the economic implications for countries like India later. But just to understand from you in layman terms, what your area of specialization is and how it can help various classes of people with heart problems.
Yes, I think that's a very valid question given my background. Angiogenesis is a new evolving science. When I entered and looked into research opportunities within that field, it was so naive that very few people knew about it. I wanted to pursue interest in that, and at a subconscious level, I always have one thing in mind, although I am so far away from India and I am an NRI, is in this lifetime, what can I do which I can help the Indian rural population? That is my focal point.
What is angiogenesis?
Angiogenesis is a science whereby nature has provided blood vessels in the heart.
Correct.
And we are not utilizing them. So, angiogenesis is externally or within stimulating those blood vessels, helping them grow, and already providing like a bypass to bypass surgery. But they are so miniature in size, they are small, they are not very powerful. I am looking into stimulating them, amplifying their magnitude of its impact, and synergizing other therapies along with angiogenesis. So, angiogenesis is a nature provide therapy. I am just extracting it from nature.
Correct. Basically allowing, let's say, blood vessels to regenerate.
Absolutely.
Or to regrow.
Absolutely.
And this obviously applies to other areas of the body excepting the heart.
For example, peripheral vascular disease, there are diabetic patients who have non-healing ulcers. Then there are hip joint patients who have avascular necrosis who need hip replacement. Application of angiogenesis is not restricted to the heart.
Exactly.
But as a cardiac surgeon, I restricted my research to the heart. Now it has gone into several textbooks all over the world, and it has multiple ramifications in all of medicine. I foresee that every future application in the world for any place in the body that is in need of blood supply, angiogenesis will be the pathway.
Okay. Run us through this triple therapy of yours.
Well, triple therapy is something that I coined, is that angiogenesis is although good, although promising, but it is in its stage of infancy. It is also not very powerful. So, one cannot give only angiogenesis to the patient and expect to heal a large muscular organ like the heart. It needs to partner with other therapies. One of the other things we will talk about later in our conversation will be stem cells. But bypass surgery and all of that has been validated that it works well. Patient lives symptom free for about 15 to 20 years. So, what I have combined is bypass surgery along with angiogenesis and with stem cell. So, a triad of this is called triple therapy. The last two pieces are important because bypass surgery cannot reach territories sometimes in patients, and that is just left alone. Our great cardiologist professionals put in stents, they do angioplasty, but again they cannot reach territories where pain is occurring or where there is what we call as refractory angina. Rather than leaving those patients alone, you might as well offer something. So, it will be a new option for the no option patients.
So, typically who would be, let's say, for people who are viewing this program, who would be the ideal person who would be benefiting from this kind of therapy of yours?
Yes, I think as most of your viewers are well aware of the fact is that bypass surgery now worldwide is not offered as a first option. It is held back for a future date. So, the first option is to angiographically view the coronary tree.
Correct.
Identify where the patient's symptoms are originating. Then you try to treat it by opening up blocked vessels by angioplasty, followed by placement of drug eluting or non-drug eluting stents or bare metal stents, whatever the optimum choice may be as determined by the cardiologist. But a patient may be there whom you offer all of this including bypass surgery, but is still left alone with symptoms. You have really not treated this patient completely. You have provided palliation, which is symptom relief, but not total symptom relief. That is where a triple therapy comes in, is to bring in a new element in this entire treatment portfolio offered to the patient.
So in a way, am I right in understanding that in cases of people who have, let's say, end stage disease of the heart and who are basically ripe for heart transplants, this could be some kind of an alternative?
Well, I don't think this is going to be an alternative for cardiomyopathy patient.
Okay.
Let me help our viewers understand who qualifies for a transplantation. Transplant is offered to patients who are in end stage cardiomyopathy, where they have gone through stent, gone through bypass surgery, are still young enough, probably 50, 60 age group, where they can still be productive members of society. They deserve a better quality of life. At this time, they are just bedridden and are taking tablets.
Correct.
Which is called maximal medical therapy.
Correct.
But even then, they are not able to attend their daughter's wedding,
Sure.
or even go with their spouse to the garden for a walk. This is a very low quality of life. So such patients in class 4 are offered a transplant. Once transplant is offered, they can ambulate and they have a better quality of life, and they can probably live a full life. The unfortunate part about transplant is that total number of need of hearts is
far
so
greater.
high.
Absolutely.
And the availability is so low. The donor heart only comes from a vehicular accident.
Sure.
Also, there needs to be a transplant center close to where a heart is needed.
Absolutely.
Okay, there need to be qualified and trained transplant surgeons. But most important is the transfer of that heart, which cannot exceed 5.5 hours. So sometimes a heart is available, a patient is there to be a recipient, but because of traffic situations and so many other things, it exceeds 5 hours, and therefore that heart becomes useless. This does not happen in the Western world, because like our hospitals in Boston and several all over the Western world, there are helipads. So the heart is airlifted,
yes, sure.
and traffic does not play a role in this operation. As an operation, transplant is a very easy operation. It is not a difficult operation. But because of the limitations of availability of hearts, now a new option is going to be offered, which is a mechanical device and what we call as a ventricular assist device, which will supplement the existing heart and act as a pump to blood. The heart has only one singular role. It does not have the role to generate emotions, as wrongly thought by many people.
Well,
but
you will have a lot of people disagreeing with that.
yeah, well, I'm happy to disappoint them. I'm happy to disappoint them. But what I'm saying is that the principal role is to act as a pump. Pump failure patients need an external pump, and I'm going to share with you what that external pump is and what it does and how it is going to obviate the need for a transplantation.
It would be excellent if you could just explain to our viewers broadly how this this instrument or whatever this technology is works.
Okay.
You know.
As I mentioned, this is the one that I'm holding in my hand is a ventricular assist device, which is a mechanical device as an alternative or a bridge to transplantation. In the Western world, for example, patients like American Vice President Dick Cheney, he has had this device which was offered to him in his hospital by his surgeons as a bridge to transplantation, because a heart which would be compatible for him was still not available. He wore it actually for quite a few years. In his case, this was offered as a bridge, and then eventually when a matching heart was available, this was taken out, a transplant was done. Why? So let me explain the technology over here, how it works. Here is the picture of a heart, and this is the pump. The pump, this part is the brain of this entire device. Blood flows in from here. This is the diseased heart, which is normally larger than normal hearts, but important thing is it is not able to pump blood to the rest of the body. So essentially the heart, being a pump, is now gone into a situation of a pump failure. This is going to address that failure. So this portion goes into the left ventricle of the heart. Blood falls right into this, goes into over here where there are titanium magnets that are moving around. Blood is ejected from here, which is connected by a graft to the aorta. Aorta distributes blood to the rest of the body. So that is essentially the operation. The way this device is powered is, this is called the drive line. The drive line is connected to battery packs on your waist.
Okay.
So after the operation, patient, just like this patient, as you can see over here, patient is walking around, in fact working in his garage in a workshop. Okay, and you can see over here, this is the drive line going into his chest. The power is coming from here. This is where the cardiologist can adjust how much blood to be given. Since he is a larger patient, you can increase it to 6 liters a minute, 7 liters, even raise it to 12 liters, 10 liters maximum. But most Indian patients would need up to 5 liters, because Indians are typically lean patients and not very big patients. This patient, all he does is goes to the cardiologist office every month, where you can even get a printout of any kind of events, cardiovascular events, irregular heartbeats and others that happened while he was not seeing you. So the doctor can adjust whatever pharmacological intervention needs to be done, or if anything needs to be adjusted with this device. About 10,000 plus of this device have been implanted worldwide, with the maximum being in United States and in Europe and in Australia.
Any in India as of now?
Not yet. In fact, there are several such devices, as I mentioned, but this particular one will now begin finding a place in the Indian market to be offered by cardiac surgeons and cardiologists to patients who need a transplant. At least they will not need to go abroad for this particular device, because the important part about this device is identification of the correct patient who will best benefit by this device. This is not a device to be taken lightly, that you start offering it to anybody and everybody who can afford it. That is, a heart failure clinic needs to be established within the hospital. Correct hospitals with the optimum setup needs to be pre-identified. The doctors and surgeons need to be trained.
Correct.
Some amount of proctoring needs to be done. They may need to be go overseas, or surgeons should come over here. A ventricular assist device coordinator, what is called VAD coordinator, is the one who will be the liaison between the patient and the hospital and the device. Putting all these things together, you will get the best results. So one should not implement a ventricular assist device or a mechanical, or common man also calls it an artificial heart. I don't think artificial heart is the correct name for this. That is a separate operation where this portion of the entire ventricle and the 4 valves are removed and a device is placed. This is not an artificial heart, this is just a VAD, which functions and performs the role of an artificial heart, but in cardiac surgical language. And even for the common man, common man can just call it a pump. Cardiac surgeons will call it a ventricular assist device.
Just to get things in perspective, you said that it's not available in India as of now. You will need to set up a whole infrastructure, you know, with the proper kind of doctors involved, proper training, proper hospitals, proper procedures. For a common person, what would this kind of treatment cost in India?
Well, I don't think I'm in a position, nor am I knowledgeable to answer that correct number with rupees attached to it. I don't think. What is more important for me is that the right institutions be established and all the other things that I mentioned. That is of, I think, primary importance. Every country all over the world, wherever ventricular assist device programs are implemented, most often will have an insurance program.
Correct.
India does not, unfortunately, have a well established, structured, engineered insurance program. So over there, direct impact, monetary impact on the patient does not play a role, because the insurance companies, once they approve this device, are going to take care of that. In India, unfortunately, it's very unlikely that the insurance companies will be able to bear an expensive operation. So rather than deflecting your question, all I can say is that this device, I think, will be accessible only probably to the very affording class of patients, which is going to be less than 0.5% of Indian population.
Okay. Coming, you know, as a natural corollary to this, you said your vision is to go and help in medical care, let's say in the rural part of India, which obviously means we are looking at some very, very cheap healthcare. Your therapies or your vision, how do you plan to bring about this revolution of cheap healthcare in India?
Well, my preference is to use the word quality healthcare at an affordable price.
Okay, fair enough.
Rather than, I think cheap means you're discounting quality of health.
What I meant was affordable.
Yeah,
fair
we
enough.
should not discount quality of
Correct,
healthcare.
correct.
Okay, this is what I did, Sanjay, at the age of 50. Is that I would always think about India. My heart beats for India. So I would think about India is that if I went to India, I'm attached to one of the best hospitals as an honorary surgeon, like Jaslok Hospital in Mumbai. I have fantastic friends in India who are all cardiac surgeons, right from my old bosses from Mumbai, like Dr. Bhattacharya, Ramakant Panda, who does great service at the Asian Heart. Coming into central India, Dr. Naresh Trehan is a great cardiac surgeon. Going a little south, Dr. Devi Shetty, and more southwards, even Dr. Girinath. So, and several other cardiac surgeons all over India. I think they perform and even give results as well as the Western world. So there is no dearth of excellent surgeons in India. Now there are fantastic hospitals that meet international criteria like the Fortis or the Max or the Apollo, or several other groups of hospitals. So that is also not the issue. So what I analyzed myself is that in my second phase of career, I wanted to play a larger role in India rather than just a surgeon role. For that, I wanted to become an economist. Because
yes,
when
you did your MBA and you did.
I took a step back. I joined business school. I qualified as a healthcare economist by getting a proper MBA. I understood globalization of healthcare, all different systems of the world. But I still wanted to zoom in on India. What can I do in India? If I just do surgery, I can help 4 patients a day.
Correct.
We cannot do more than 4 surgeries a day. Am I really having an impact on India? The answer is in the negative. So I wanted to play, how can I touch larger pool of patients? And here you're talking about million, if not the entire 1.2 billion population of India. For that, I wanted to play a role as a reformer. I wanted to do some scripting on the policies of India that can impact the rural population. Of course, the affluent class also gets affected, but this is the underprivileged class that really needs attention. Somebody needs to take care of them.
Sorry to interrupt at this stage. It's very interesting what you're saying. Could you please expand on this? I really want an answer to this question. You are planning all this in, let's say, in the latter half of your part of your career. Could you please break it down for the viewer? I mean, let's say 10 years from now or 5 years from now.
Yes.
What everybody who is more interested, they don't know what's going on behind the scenes or what you are doing or what other doctors are doing with good in mind. What do you see? I mean, like today, if you go to a village, if today you go to a small town, if today you go to a large town, as you said, the Indian hospitals, doctors are absolutely as good as anywhere in the world.
Absolutely.
How does this revolution come about? I mean, when we are talking of, getting, let's say you specialize in heart disease, okay? You're a specialist heart surgeon. Do you see, let's talk about your typical triple therapy which you've devised, for which you've won so many plaudits. Can that percolate down, as you said, affordable?
Yes.
Will it at some stage percolate down as an affordable treatment for people even in small towns and villages?
Yes. I think that is one of the clinical segments of my to-be contribution to the Indian people, is that angiogenesis, you don't need to buy anything.
Correct.
Because you're stimulating the patient's own blood vessels, which were offered by nature.
Correct.
So there is no cost attached to it. Stem cells we are aspirating from the bone, which is the iliac crest, filtering it, injecting it into the heart. So the patient's contribution of stem cells for his or her own health, no additional cost attached.
Correct.
Internal mammary artery of the patient, it just needs a procedure which the cost can drop because no new devices are going into the patient. So you're dropping the cost of healthcare right over there. Now there are new therapies like non-invasive shockwave therapies. Shockwave therapy is, without performing open heart surgery, you can stimulate angiogenesis by providing serial shock waves. And this is done by Modulith Shockwave System, a Switzerland based company, that without it is an outpatient procedure, a small room, a small device. This is offered not to patients who should ideally have bypass surgery. This is who are just sitting, who do not access a transplant or a ventricular assist device. At least you are able to provide some quality palliation to the patient. Okay. So that is going to be one of those clinical therapies. But from the economic side, where I want to play a larger role is in the reformation of the fractured healthcare system of India. Let us accept the fact.
Do we really have a healthcare system in India?
Well, we have a very sporadic, tattered healthcare system, because the definition of healthcare in India is doctors, nurses, hospitals, you have access to it and you call it healthcare. But we really do not have a healthcare system. For India to be qualified as a developing country, you need a good healthcare system.
Absolutely.
So I want to play a role in the scripting, in the reformation of that healthcare system. One of the